Hello everyone. Today I have for you a case of posterior polar cataract. So this was a 20-year female with bilateral posterior polar cataract, and here we are operating on the right eye. As you can appreciate, this is a fairly dense posterior polar, and a true posterior polar can be a very tricky situation because there's always a chance of posterior capsular rupture which can occur at any stage of the operation, even while placing the lens or closing the wounds. So let's go on with the surgery. The incisions are made and the capsule is stained with trypan blue and then washed off. Dispersive viscoelastic is used to fill the anterior chamber before proceeding for the capsular rhexis. Some surgeons prefer a vertically oval rhexis in cases of posterior polars. Here I am doing a round capsular rhexis, slightly smaller than the usual size. The idea is to allow me to do a optic capture if the need arises. Now always decompress the chamber before any hydro procedure. It's very important. And what is more important is not to do any hydro dissection in this case. So what I'm doing here is simply using the irrigating cannula to mechanically create a separation between the capsule and the underlying cortex. Now this can also be done with an iris suppositor, but I prefer this technique as there is no need to change the instruments before going in for the hydro delineation. A multi-layer delineation is done and viscoelastic is used to protect the endothelium before going in with the phaco probe. The bottle height and the phaco parameters are reduced, and as we can see, the nucleus is soft and with minimal power, and just aspiration it is emulsified. Now before withdrawing the phaco probe from the anterior chamber, viscoelastic is instilled in the eye so as to maintain the chamber and not cause any sudden change in the chamber volume, which can disrupt the already weak capsule. So here a little bit of viscodissection is being done. Following this, irrigation and aspiration is done to remove the cortical matter and the epinucleus. Now this step is done slowly, and what I'm trying to do here is shear the cortical matter away from the capsule in a flower petal manner, bringing it to the center and keeping the central pole for the last. So at this point I realized that there's hardly any cortical matter in the center, and what is left is a plaque on the posterior capsule. Again, before changing the instruments, viscoelastic is injected while the infusion is still on, and then the infusion cannula is withdrawn. The remaining cortical matter is removed and viscoelastic is injected before implanting the lens. Here I am inserting a single piece foldable IOL. It is always a good idea to keep a multi-piece backup for a posterior polar in case you run into a pole-to-pole split in the posterior capsule. Now it is time to remove the central plaque. So one can do a posterior capsular rhexis, but here I am doing a capsulotomy using a vitrectomy cutter. Keeping a high cut rate, a small capsulotomy is made and a small amount of anterior vitreous is cleared from behind it. Also using the same cutter, the viscoelastic is removed from behind the lens and also from front of the lens from the anterior chamber. Managing a posterior polar does require a lot of patience. Even in the best of hands, the PC can give away. What is important is to perform the surgery slowly, taking care at each step, and in case there is a posterior capsular rupture, knowing how to effectively manage it. The case is concluded with hydration of the incisions. Hope you enjoyed the video. Thanks for watching.